Let me see. Good. So I'm going to talk about the deep brain stimulation surgery in regards to Parkinson's disease. I will try to make it practical, straightforward, but I also want to take this opportunity to highlight some of the innovations that are going on for Parkinson's disease. Because this is not a promotional program, I'm not being paid for it. I will also mention some off-label kind of future potential uses for this technology and where it might be heading. So to give you an idea of, yes, it has been there for a while. You probably have heard about it quite a bit already, but it's not an old it's not an old technology. It's moving rapidly. It's growing very fast, and there are new uh, resources in the market, institutions like Abbott, who are innovating this. And Boston Scientific is another name, and of course, Medtronic is now also in the competition and trying to innovate to try to make this therapy better and more adaptive to the patient. And I'll try to mention a couple of those things. So I will try to finish it quickly so that I can take some time to answer your questions. And I would love to hear your comments about this. In the end, it is about you. I'm speaking as a peer, and not as your physician, but as your friend. So feel free to drop a question in the chat box, or raise your hand, or keep it for the end, and you can unmute yourself and ask me your questions. Uh, very good. So deep brain stimulation surgery. The idea is to have a wire inside the brain that is hooked up after running around behind the ear down to the chest with a battery. So you can see the battery on here that basically controls what settings the wire is giving the current at, and that settings determine what results patient get, good or bad. And the hope is to find settings where patient get great results for their symptom control for Parkinson. It does not stop the progression of Parkinson's disease. It doesn't cure Parkinson, but it provides remarkable benefit in symptoms to selected patients. Unfortunately, it's not for everything. It doesn't cure every symptom, and it's so that's why it's not for every patient. But in properly selected patient, we can have really, really wonderful result and great improvement in their quality of life. And and you can already see innovation right in this first slide, where you can see an iPod Touch or iPhone-like device where patient can have this wonderful interaction with their device on their own, so they can have more and more control and freedom of using this therapy. I'm starting to become a big believer in it. If you have control in how you take your medication, your pill, your Cinemed, then you should have a control on how your brain is stimulated, and you should have an understanding of what's going on, and an ability to adjust to it or adapt to it within your capacity and your interest. So um, I'm going to skip the patient story so that I keep this talk as non-promotional as possible. But I will show you um, some patient videos. So this Parkinson's disease is a very common problem. It is about a million patients or people in the United States alone, and 7 to 10 million across the world who have this illness. And 60,000 new patients get diagnosed every year. So with that ratio, just in Nebraska, we expect anywhere from 13,000 to all the way up to 20,000 patients within Nebraska at a time. And then, based on the registry number that we have in Nebraska, we diagnose anywhere from 800 to 1,200 new patients every year that get registered. And there may be a few hundred more that don't get registered. Um, in Parkinson's disease, there is slow loss of brain cells in a part of the brain, and those brain cells make dopamine. So the main problem for the physical symptoms, the motor symptoms, is the lack of dopamine that we try to balance with a medication. Um, but there are many other non-motor symptoms that happen too, some related to dopamine and many not related to dopamine. So loss of sense of smell, sleep, constipation are the non-motor symptoms in addition to motor symptoms. So motor symptoms are Almost all of them are from dopamine loss, except for a couple, such as freezing of gait, can be from acetylcholine or other problems. And some of the non-motor symptoms are from dopamine loss. We can actually see the loss of dopamine in the brain. So what you're seeing, this picture on the screen, is two different people's DAT scan, DAT, which stands for dopamine transporter scan. And what we're looking for is the dopamine transporters in the brain. And those dopamine transporters highlight up with this dye as bright yellow. So you see on the brain on the left hand side of the person, large, big comma shaped or comet shaped yellow areas on both sides of the brain. So two of them, which is healthy dopamine transporters, meaning there is a lot of dopamine cells. Now on the other scan in the picture is a patient who has lost a lot of these dopamine transporters because of loss of dopamine cells, and that's why those areas have much more shrunken and reduced. So what we try to medically treat the disease, we try to replace that dopamine that is lost. We cannot bring those dopamine cells back, but what we do is that the leftover cells, we try to have them make more dopamine so they can compensate for the cells that are gone. And there are various ways to do it, but that's not the focus of the talk today. And we have over the last 100 years learned how to replace the dopamine in the brain in various ways. However, there are problems with using medications that we know that over time the medication response is not as smooth or as effective throughout the day as we want it to be, and it could be also a response that we don't want. So this is a patient in 3 different states. I will play the video. This first video, patient is having good benefit of dopamine replacement, although there is still tremor, and he still looks a little slow, but he can run very well and he can talk very well, but he's not like that throughout the day. And there are times when the medication wears off, and this is what we call the off state. So the second video, now the tremor is much worse. His walking is much shorter steps, although he's still trying to walk pretty fast. But you can see he is not as fast as before, as not smooth, and there is much more severe tremor present. But not only that, when he takes his medication and medication kicks in, he goes into an hyperactive state. So there's too much effect of the medication, unfortunately, because of the brain changes. And now when the medication kicks in, he's very restless and he's having these uncontrollable movements which he has no control over. So the day is going between these 3 states multiple time, and it may happen with every dose. So there's 4 or 5 doses that he's taking. He may go into this on off dyskinetic, back on back off throughout the day. uh, and that can be very terrible, very disabling. And then we sometimes even calculate how many hours a patient spends in each of these states. It may be that he spends 4 or 5 hours in on stage, 4 or 5 hours in off stage, and another 4 or 5 hours in dyskinetic state throughout the day. Very, very bad situation. So that's what this is showing, this graph here, that this white space in the middle of the graph, marked by the TW on the left, is the therapeutic window, the good state, where we want the dopamine to be and the patient to have good result. But the green line is the level of dopamine in the blood and in the brain, which is fluctuating. When it goes up too much, the blue area is the dyskinesia, and when it comes back down, the light blue area with the red dots is the off state. And as you can see, if this is one day, how roller coaster of a day the patient is having and is being all over the place throughout the day. So what we're trying to do with different treatments with the deep brain stimulation is to make that graph very smooth, or as smooth as possible, so that we take away the time when the patient spends in dyskinesia. We also take away the time the patient spends in off state, so that the on time increases significantly. And deep brain stimulation does that by stimulating and blocking the circuits in the brain. So kind of numbing the brain, blocking some circuits which are overactive, rather than increasing dopamine. So it's a non-dopaminergic change, non-chemical change, and electrical change. However, as the stimulation goes on, there are probably some changes in how the brain neurons connect with each other, brain cells connect with each other. So there are probably also some downstream later on chemical changes that happen in the brain, but the initial effect or impact is an electrical signal in the brain. And so what we can do is to make a remarkable effect. I believe these are patients who have had DBS placed, but the stimulation is turned off right now, just to show that without that stimulation, what their actual Parkinson is like. So that's one patient. And that's a second patient. Both have really bad tremors in the hands and also in the jaw in the second patient. And then the gait is also very affected, where they're walking with very short steps without lifting it up off the ground too much and without swinging their arm. Now, these patients, when their DBS is turned on to have that electrical stimulation in the brain, they have significant improvement in their symptom. So this is the first patient. The tremor is barely there in the left leg, and the hand tremor is gone, and she's more quick with her gestures and movements of the arm. And here's the other patient who has partial improvement in the tremor. You can actually see how the stimulation slowly ramped the tremor down, and a patient's jaw tremor is gone. And the third patient is going to walk much better than before, long steps, slightly better clearing off the ground than before. Very good. So the DBS idea, that the area where the DBS can work, was discovered as early as in 1930s. And initially, because we didn't have a way to stimulate the brain, we were just basically damaging that brain, what we call lesioning the brain, to get the benefit. But we realized that damaging the brain is a permanent situation, not a good idea. We want something that is changeable, adaptable, adjustable. And that's where uh, we developed this, adapted the pacemaker battery to also do stimulation in the brain, but in a way where we could program it, we can change it. And then in 1995, we got the first approval for essential tremor. And then in 1997, we got the approval for Parkinson's disease initial, and then later on, standardizations were done. So it has been there for a long time. It has been there for 20 plus years that we have been using it. But what's remarkable about it is that now we have done a lot of new innovations to it. We have taken that old idea of stimulating the brain and have taken it to new heights, built new controls to it so that we can even further adapt to individual patients in getting the results. So that's what I'm talking about. The lead is there with a dashed line in the brain, going to area number 3 marked here. Number 2 is where it's coming out of the skull, runs under the skin, all closed system down to the battery in the chest, which is 1. And what it does is that it basically narrows down that fluctuation so that you have more stable day. And the need for medication could also decrease in some patient, but that's not our goal. Our goal is to make the day more better and smooth. Now, what it works on, it works amazingly well on the tremor, really, really good. It also works reasonably good on the stiffness and slowness. And it also takes away that extra movement, the dyskinesia, very well, extremely well. But Parkinson's have many other symptoms, and it's not necessarily effective for all the other symptoms. The gait, walking gets better in about half of the patients or so. Freezing gets in better in some patients, but other problems like speech problem, sleep problem, mood problems, constipation, those kind of things typically don't respond to stimulation, although there are always exceptions, but they usually don't respond to stimulation. But the disabling symptoms like tremor and stiffness and slowness can be made a lot better. Now, this picture kind of summarizes a lot of innovation that has happened with these new technologies that are coming up. So this particular example is from Abbott, because as I mentioned, the slides are from Abbott, but there are innovations going on from Boston and some from Medtronic too, the 2 other companies that have the DBS system. But let's just take this as an example of what those innovations are. So there is innovation in the surgical techniques of how the surgery is done, which patient may not get to see much of it. That's behind the scene or under the hood, but the surgeons and the physicians know about those improvements. There is also improvement on how we can stimulate the brain based on the lead. So in the top right corner, you see two wires coming in, and those are basically what we call the leads. And at the tip of the leads is those areas where the current comes out from. We call them contacts. And it used to be that you have one large contact that wraps around the lead in a ring form. So you could see here there is a ring at the tip here, and then a ring above it, and above it, and then above it. And it used to be for 20 plus years, there was a full ring, a combined ring. So when you turn it on, the ring will turn on the current, and like a light bulb, it will go all around 360. It will just spread equally all directions. So one innovation that has happened with the advancements in the technology is that now we have leads where the ring is not constant, has three different pieces or segments, and we have the ability to turn on only one of the three pieces. So rather than sending the current all around to 360, we can now preferably send current to one side where we are turning it on, and have less current going to the other side, because we don't necessarily want to stimulate the tissue all around it. There is certain part of the brain where we want to stimulate, and there are other parts of the brain we don't want to stimulate because that could cause side effects from stimulation. And part of the process we do of programming is to figure out where are those bad areas we don't want to stimulate, where are the good areas we want to stimulate. And we have different ways of trying to send current more to the good areas and less to the bad areas. But now one additional tool for us to do it better is to have these segments which allow us to shift current a little bit to one side, and that makes us move towards the good area, move away from the bad area. But another innovation, which I think is equally great for me, is the amazing advances on how we do those programming or finding out. It used to be that those controllers were very scientific. It was like almost having a scientific calculator in your hand, and then teaching someone on how to do those programming was a very complex task, and it would take years of practice and training before you would know how to program someone, and it will take hours to figure out how to program someone. So one of the remarkable improvement going on recently from companies like Abbott, and also from Boston, and Medtronic is trying to keep up with it too, is to come up with ways of doing programming effortlessly. It is very easy to do. It cuts down the time much less, and you have more information available. So if you see this large big iPad in the middle of the screen, you can see a lot going on there, but it's very useful information. You can see the lead in the center with the ring segments broken. You can see some mark on the left like triangles, which is basically a way that we can record where the benefits are, where the side effects are, and which will tell us where the good areas are, where the bad areas are. You can see the green bar on the top with two dots, which is tracking for us visually as physicians on where is the good effect, where's the bad effect, how wide and separated they are, or how close they are, and how are you seeing at a low effect or a high amplitude. These kind of information is extremely useful when you're doing programming. It makes your decision much more informed, much more effective. It makes your decisions much more quick, and it makes you much more smarter in making those decisions. So now with this kind of tool, someone can be as good as me, who has been doing programming for 7 years, within 7 months, or maybe even 7 weeks if they spend enough time with it. And even behind the scene, which you cannot see here, there are what we call almost kind of artificial intelligence. The programmer can give suggestion to someone like me. This computer can, iPad can, hey, these might be good ones to try, or these have the most effects, or this or the lowest current use. And that kind of information was just impossible to have before. You could, doing that calculation on computer and on a paper would have taken hours to figure it out on what are the good contexts, but all of them are being done instantly as you are testing the patient, and the computer at the end can list all of them for you to say these are good ones, these are bad ones, or these are efficient ones, low current use, any sort of way. There's so much information there that I can't even explain all of it in the short amount of time we have together. So this innovation of programming, lowering the barrier of therapy so that more physicians can do it for you, and they can do a better job at it even with less amount of training, is, I think, is even a bigger breakthrough than segmentation of the leads. Even if I had no segmentation, if I had this, I would have been so happy, because I can see now that I can teach people much more easily how to do this programming and have more people do it. The process is multi-step of putting the leads in. This is what it's showing. We take pictures of the brain, computer marks where the area is where we want to put the lead in. Then we get information on the distance from the top of the skull, how deep we need to go in, at what angle we need to go in. And in the middle, you see this kind of a frame, a mechanical device, which allows us to then use that numbers to go exactly where we need to go to do the implantation. And then we verify it by doing testing within the surgery in the OR. So patient is awake. Although as the techniques are getting better, more and more centers are looking at doing the sleep surgery. But still, I would say 90% of the university hospitals are doing awake surgeries where they test the patient and make sure that the lead is in the right position before they lock the lead. And then they will implant the battery that is usually done as a second surgery later on, rather than keep going for the surgery. Some centers, very few centers, will do it in a single day, where in the morning they will put the lead in and in the afternoon they'll put the battery in. But majority of the centers, more than 90%, will do it in another day, a week later, and then hook it up. And after it's hooked up, we wait for a few weeks, anywhere from 2 to 6 weeks, for brain to heal from the surgeries, from poking, before we turn it on. And then, as I said, what we need to do is to figure out where the good areas are, where the bad areas are, and how can we get to the good areas without hitting the bad areas. And that's is basically uh, shaping the current. In any more detail will be too confusing if I go into details, but the idea is to use various tools we have, such as segments, such as other things, pulse width, frequencies, to try to find a way to get the current where it needs to go to get the good benefit and stay away from the bad areas. And that process, it's a process because it takes us time to figure it out. But with these new technology, that process is becoming shorter and shorter and faster and faster. Very good. So I get I mentioned some of it, and here's some visuals of it. Actually, there's a video. Let's play this video, and it shows you exactly that small area. That area is size of a pea, a chickpea. It's about 6 millimeter, 4 by 6 millimeter, where you need to get the wire in. And not only that, once you have the wire in, this red blob is kind of the current coming out of that lead, which we are trying to move around to find just the perfect spot where the current needs to go and stay away from the bad areas, because brain is very condensed, compact. Bad areas are pretty close to the good areas. They're not too far away. So, a millimeter off and you're hitting the bad area. And that's also true for the lead. If the lead is placed more than 1 millimeter off target, then you have a high chance of keep hitting the bad areas in and not be able to get the benefit without side effects. Very good. So this basically is a study from Abbott. Again, as I said, these are Abbott slides where they're showing that they showed good benefit of their therapy over medication. So 20 years ago, we initially proved that the stimulation of the brain is very effective. And then with these new companies coming in, Abbott and Boston Scientific, one good thing was that they redid a lot of trials to again show us how useful this technique is, how effective this is. And they also show that they're equally good as the other devices that were already in the market. And now they have these additional tools that didn't exist before. So um, how much benefit we get? There are two ways to look at it. One way is to look at it in terms of hours in the day. So as I mentioned, you're having some hours of on, some off, some dyskinesia. How much increase in the on time? How many hours more every day you will spend in the good on time? is one way of looking at it. And the older data was about 4.7, 4.6 hours, but the newer data is 6.1 hours. So it's at least 6 hours of better on time, is what we're seeing with the recent studies. The other way of looking at it is how much percent control we can get. So uh, with a tremor, the results could be more than 90%, closer to 95% of a tremor control. And with other symptoms like bradykinesia, it could be 70 to 80%. And as I said, some symptoms don't respond as well, where the response could be only 30 to 50%, or no response whatsoever. So let me see. So side effects can happen from the DBS. There are two kind of side effects. One is from the surgery itself, and surgery is a brain surgery. So we need to be cognizant of that, and we need to be mindful of that. That you could have infection from the surgery. You can have bleeding in the brain from the surgery, and we can have seizures, we can have effect on the heart as the surgery is going on. So those are the immediate problems. Those problems happen during the surgery, right after the surgery, and after a few weeks, they are settled, and usually we can manage it, except for things like bleeding in the brain that's permanent, like strokes, or death can happen, which the risk of that is now down to 1 in 200, or half a percent. And usually for older age, so more closer to 80 years of age or above 80, you are, the higher the risk. Presumably, we don't have enough data to say, because the deaths are so few. Even if you do a study with 200 patients, that's a large study for DBS, multi-million dollar, 100 million or more. There's still only maybe one death, if you are unlucky, but not more than that. So you cannot make good conclusions from such small numbers. Um, but after a few weeks, when the surgery is done, you're over with these side effects, and those are not a problem anymore. Maybe they never happened. In about 15 to 18 out of 20 patients, no problem happens with the surgery. So it's a pretty safe surgery, in compared to other surgeries. The other problem, which are more common, are the problems from stimulation. So you turn on the current and you're hitting the bad area, and you try to move that current away from the bad area to the good area. And a lot of time we're successful, especially if it was a good surgeon who plays the lead pretty well. But sometimes that becomes a challenge, that we are not able to get benefit without hitting the bad area. So you get benefit plus you get side effects, which could be the speech problems, and effect on gait or balance or falls or even memory and thinking. And we work on it to make it better, but sometimes the wires just are not in a position to make it better, or the brain is in a way where we just cannot make it better. I mentioned those side effects that again listed here in details. And I guess because we have a few minutes, let's just hear from this patient.
And I wish I had done it earlier. I really do. I could sculpt again. I could do my digital painting, all kinds of writing. I couldn't do any of those things before. I still have Parkinson's, but nobody knows it. That in itself is a huge thing, to be able to interact as a normal person. Just be normal. That's all I want. That's not a lot to ask. The game changer really was being able to get back to sculpting and to have that fine motor control that I never had in the past. For 10 years now, I've been waiting for it. And I used to say to myself, I could just have one day, just give me one day. And now I've got every day. It's amazing.
Very good. And then, of course, this is all Abbott stuff, legalese that I will skip, and references. And I actually will stop here, and I will actually start answering the questions that I have already see in the chat box, and that will give you time to come up with more questions. I really wanted to save time to so that I can focus on areas that are important to you, rather than just telling you things that are important to me or interesting to me. So let me start with questions up top. I see a question about what is the process for making sure the device is set properly and how long does that usually take? So currently, the way the programming is being done, the process takes about anywhere from 3 to 6 visits generally. Each visit is about 2 to 4 weeks apart. So you come in, you stay for a few hours, usually 3 to 4 hours, and then you go back home. You try that, and then you come back for another testing. Sometimes within a few days, sometimes 3 weeks later, and then you do that a few times. And every time that you're coming back, the time you spend with us becomes smaller and smaller. And then so that the tweakings are going on, which is doesn't take too long. Initially, it takes a long for us to know exactly where the good areas are, bad areas are. And that process we call mapping, and that can take 4 to 10 hours or sometimes even more, depending on how the brain is reacting. So all in all, I will say it takes about 3 to 6 months after the surgery to get to the setting where you will say, okay, this is kind of my baseline setting, and then we may change it in once a year or once every other year based on how the Parkinson's is progressing. Next question I see is that how can you tell if the programming will be permanent? And then there is a concern that the effects you see in the office doesn't seem to last, and then the next day is different. So um, the when we turn on the current or we change the current setting, there are immediate effects that happen right away. That typically takes about seconds to a few minutes to see those results. There are some late effects that happens an hour later, 2 hours later. That's why initially we keep the patients for a few hours to our clinic to see those late effects. But then there are really late effects that build up over days, and that can happen one day later, 3 days, 5 days, up to 2 weeks later. And that's why when we make a change, we don't like making another change for another 3 weeks, because the effects from that change can continue to happen even 2 weeks or 3 weeks later. So it would be too soon to give up on it or change it without knowing what would have happened if we had given it time. The brain, as I said, brain has immediate stunning effect, but then the brain forms new neural networks and connection, sometimes within hours, sometimes within days. That changes what was going on, and that's why the process has to be done slowly and carefully. And we try not to make too many changes without giving enough break in between. Otherwise you're lost. You're not sure what exactly did what. Programming is almost never permanent, because there is always a need to tweak the programming, um, because Parkinson's is a progressing disease. However, once you find a good setting, you usually don't need to change it for 6 to 12 months. So we do routine checks every 6 months to make sure that the battery is not turning on and off on its own or shorting, or there hasn't been any damage from a fall or a hit to the battery or to the wires. But a lot of time we don't have to do change every 6 months, and the disease moves so slowly that if you are having good results with your battery settings, you may not need to change it for a year or so. Just like medications, when you're on a medication regimen, you don't need to change it for every few weeks. You will wait 6 months, 12 months, sometimes 18 months before you will make a change. um, what is the risk of brain bleeds that could damage surrounding area of the brain? Brain bleeding risk is about 1%. So 1 in 100 can have a bleeding in the brain. And then risk of death from bleeding is 0.5%. So out of two people who have had bleeding in the research studies, one of them died because of the bleeding being too significant or too bad. So bleeding is usually the cause of death. I have almost not heard of any other reason to have death from anything else from the battery. So the bleeding risk without having death is about um, 1%. And that bleeding, even if it doesn't cause a death, can cause stroke like symptoms like weakness or numbness. And may go away over time. Bleeding usually resolves and only a small scar tissue is left. So usually bleeding kind of a stroke is a good prognosis, but it can take 6 months or a year for that good to go away. But there could be some permanent deficit that may never go away from the scar tissue. Um, Average lifespan of this device. So the device itself is made of component that can last 100 years, but the battery that is providing the current to the system has a limited life. So the current batteries like Abbott system has, the newer batteries Boston has, they typically last anywhere from 4 to 6 years. I would say 5.5 is an average life. Um, and that depends on how much current is needed to stimulate your brain. If you need more current, it will run out faster. If you need less current, it will run out later. um, there is new batteries now which are rechargeable, so you can wirelessly charge them. So just like a phone wireless charging, you put a charging pad on your chest from the outside the skin, and then it wirelessly can charge your battery. And you may have to do it an hour every week, or half an hour, 20 minutes every day, or something like that. Those batteries are allowed or approved to be used for 15 years. They actually can last longer than that. My impression is that they can last 20 plus years. But right now, the approval is based on the testing available is 15 years, but that approval may expand over time as we see that those batteries are doing really well. But recharging is kind of an additional thing you will have to do. The other batteries that only last 5 years, a third of the time, you don't have to do anything with them. You don't have to worry about your charging or a charger cable or things like that. So I so far still prefer those kind of batteries which you set and forget. And 5 years is a pretty long time. The other reason I like them is that the technology moves so fast that in 5 years you may have something completely different, much better. So you don't want to now feel that okay, now I'm stuck with this 15-year battery because insurance not paying to replace it because it still has 10 years to go, while there is such amazing batteries available in the market, new technology available. That's why I don't want to, with the current pace of technology, I don't want patients to be tied into a 15-year contract when they could have a 5-year contract, if you think of it that way. um, how does somebody make an appointment to see me if they're interested in DBS? So, I disclaimer: I'm here for education, not to get more patient for myself. I'm happy to see you guys, but I'm not the only person who does this. There are many of my partners who do it. There are other neurologists in other hospitals and other clinics who can do it. So the easiest way will be to ask your regular doctor, your primary care, to refer you to a neurologist who takes care of Parkinson's patient. If you're already seeing a neurologist, then ask them to send you to a movement disorder doctor who does DBS, and they will know. They send patients often. We have these referral networks. All of us who do DBS have these referral networks, and they can do it. And University of Nebraska typically wants patients to be referred by a physician. So patient self-calling is typically in our clinics and neurology clinics, I have heard, is not the preferred way. So I think, and it's easier for you to have your primary care make the referral, your primary doctor or your primary neurologist. But you can go to the University of Nebraska Medical Center's website and or Nebraska Medicine website, and you can search Parkinson's disease, and the doctors who do Parkinson's care, including me, will pop up over there, and there will be a number listed to call to start the process. And even if you're not sure with your primary care, you can just call that number, and then we can walk you through that process or any other process that's necessary. Insurance, does insurance cover DBS? Yes, it's FDA approved for Parkinson's disease. All three devices are Abbott and Boston and Medtronic, and they are fully covered within the normal limitation, which is you have your out-of-pocket deductible, which this is very expensive therapy, so you will hit your out-of-pocket maximum right away. But after that, everything else will be covered by the insurance. All insurances cover it, including Medicare and Medicaid, I believe. That might be harder, but it's fully covered. I have not had any patient not get the surgery because of insurance not covering it. I've had patients who have not had insurance, but that becomes a problem because it is very expensive therapy. You cannot afford it out of pocket. but insurance is covered pretty easily, and usually the doctors take care of that, so it's not something you'll have to worry about. Doctors will take care of everything. uh, so question, would I still need to take my oral medications? And the answer is yes, you will still need to take oral medication. The need for medication would go down. For some it goes down by a lot. Extreme example, one of my patient was taking one pill of Cinemet carbidopa levodopa a week. Now he's taking more, but after, for the first year after the surgery. But that's extreme example. But for most patients, the numbers go down quite a bit. Um, but that's not the goal. The goal is to keep symptoms control, a good benefit with the combination of medication and the surgery. The reason we still need medication is because there are symptoms that do not respond to DBS, but they do respond to Cinemet. So the best example I have is fatigue and mood changes. They do not respond very well to DBS, but they do respond very well to Cinemet. Cinemet is kind of an motivating drug. It's an elevating drug. You feel much better, much energized, more motivation, more energy, less fatigue, and that uh, is that's really good um, response that you still need medications for. So question, would I still need to get Botox shot? So Botox or botulinum toxin injections are done in patients with Parkinson's disease for a couple of common reasons. One is for muscle spasm, what we call dystonia. So you can have a dystonia in your jaw, in your neck, around your eyes, in your foot, in your hands, where the muscles are tight and cramping, and the medication is not making it better. And you can inject botulinum toxin injection into those muscles, loosen up the muscles, make them relax. That lasts for 3 to 4 months, and then you can get injections again. Uh, the DBS can work so well to improve the dystonia to a point where you would not need the Botox injection. The chance of that, I don't know if there's any good study on it, but if I have to guess, I will say it's about 60 to 70%. So it's not 100%. There is still leftover spasm, muscle spasm that you need the shots for. But there is a good chance, 60 70%, that the DBS can control the dystonia enough that you will not need the Botox injection or botulinum toxin injections anymore. Another common reason where we do the botulinum toxin injections in Parkinson's disease is for drooling. If you have too much saliva in your mouth and your mouth is not completely closing, then you can drool. You can drool at your meals, or you can drool all the time or during your sleep. And we can give the botulinum toxin injections around the jaw in the glands that make the saliva, so that there is no drooling anymore, and then again it lasts for 3 to 6 months and you can repeat it. Now drooling typically does not get better with the DBS, and if that was the reason to get botulinum toxin injection, then unfortunately it's very likely that will be necessary to be continued. Drooling does not, your swallowing doesn't get better, mouth closing may get slightly better, but saliva kind of still comes out, and it might be necessary. So any plans to make the battery unit smaller? Yes, there are plans to make battery units smaller. There is actually a battery already out there being tested. That battery is from Medtronic. It is a very small, very, very small battery. It's like smaller than a pack of gums. Those old packs was kind of like not the one where you pop it out, but the one where you open it. So it's a very small one. It is designed to be placed on the skull, so it will stick out if it was just placed on the skull. So the way I've heard or seen is that they will make some shallow kind of a space in the skull. So they will scrape out some of the bone, make a space there. Then they put the batteries on, but the batteries are on the skull. Now there's a small battery, so they of course don't have that much charge or juice. So you will need one for each side. You cannot use a single battery for both sides, and still it will only last for 18 months to 2 years, not a whole lot. uh, and then you'll have to replace it. So there is an effort to do it, but remember, the size is basically driven by the battery itself and not the electronics, and some of the limitations because of all the shielding needed so that it's isolated and not affected by things around, waves around. Um, who is a good candidate for Parkinson's disease for DBS is the next question. A good candidate for Parkinson's disease is someone who has had good benefit from medications early on and now they are having benefit, but the benefit don't last long enough, and they go on into on and off states all the time, and they're having more than 3 hours of off time during the day. They still respond to medication, but it just doesn't last long enough. And that's kind of the basis of it. There are additional details to it, but that's too much information to be covered in this talk. But that's kind of what we look for to start with, and then there are additional things we'll have to screen for. Things are what kind of symptoms, how much they respond, and how much wearing off is going on, what kind of Parkinson's it is, and cognitive changes and mood effects and things like that. There are some details to it. Next question: do you build up a tolerance for DBS? Yes and no. There is less and less effect of DBS over the years. So 5 years now, 10 years from now, after having the DBS, it will not be as good as it was the first year, but it's more so because of the continued progression of Parkinson's disease. Remember, the DBS is not stopping the progression of Parkinson. Parkinson's is going to continue to progress. And unfortunately, the DBS, you could increase the stimulation to keep up with the control, but there's only so much you can do it. And then there are other symptoms that keep showing up that doesn't respond to DBS, or they were already there and they keep on getting worse. And even if you increase the stimulation, they may not respond. So yes, you can adapt to the increasing symptoms up to a certain point, but so in the first 2-3 years it's great, you have about same benefit, but after 5-10 years it may not be as good as it was before, but not because of the original symptoms that it was responding to. So there was a data that was published 7 years and 10 years follow-up, and they showed that even after 10 years the amount of improvement on tremors and stiff was about as good as before, as the first year. And the bradykinesia was about 80 to 90% as good as the first year. But as I said, there are other symptoms that can happen with Parkinson's. So Parkinson itself will move, and the battery will not hold it. Next question: do you have to increase stimulation to have same on effects? I think it's in the same context. Yes, if just like increasing medication over time, that you're responding to Cinemed at 6 tablets a day, and then after a year you're not having as much benefit, so you increase to 8 tablets a day. And same is for stimulation. You have benefit, and a year later you're seeing less benefit because the tremors have increased. Then you can increase the stimulation to get the same on effect, same tremor control over time. So the good thing is that the battery is adaptable. You can keep increasing it up to a certain limit. So a very nice question from Barry about, can you update the software without the surgery? And the answer is probably yes. I would say yes, but not for all devices. You have to design a device from ground up, from scratch, to be ready for that, and then you have to have right kind of connectivity, and there are many technical details to it. So Abbott is known for this, that they have built a device where they can update the device, and they have that technical ability, and they actually did that by their MRI conditionality that came out. And they can do a lot of updates in the controller, the way you control the device. That's very easy, and they keep doing it very rapidly and very fast on how you program the device and how you control the device. But the device itself that's sitting inside, that even that can be updated. But as far as I know, and I might be wrong, that Abbott has that capacity. I don't. Medtronic definitely does not have that capacity. Their devices are very secured to a point that even they cannot change it. And I think Boston Scientific device is not upgradable either. But that's something I'll have to confirm. But Abbott is upgradable. But eh, that's a significant thing. That's something that should not be taken lightly. Upgrading the device itself is a challenging thing, and it has to be done very carefully and through a long process through FDA. But the great thing is that the controller, it used to be you will have this brick of a controller that was fixed. That's what you have, and you have to live with it. And there was not much of a change to it. Maybe 5-10 years later they'll come up with a new brick. But with this new iPad based controllers, it's so remarkable that you could update it, just like updating a software, and give more controls, more features, more benefits to the patient, to the physician. And even to the patient's own controller can be updated and given more control, more and more control that didn't exist before. So that's remarkable change and innovation, and more of those innovations are coming on in the future. It's almost 7:30, so I'm going to take a pause here and see if Rich or Amber has any comments, and if we see if we're going to give mic to someone to make any comments.